Welcome to the first week of the Public Health Surveillance course. I'm Dennis Nash, a professor of epidemiology at the CUNY School of Public Health, and the focus of this session is the global burden of disease and historical context for public health surveillance. This is one of a few recorded lectures for session 1 this week focused on these issues. The goals of this session are to describe the burden of disease in the US and globally, to introduce the definition of public health surveillance that we'll be using during the course. And lastly, I'll also try to help provide an understanding of how public health surveillance fits into what we call the public health approach to disease control and prevention. So let's jump into the global burden of disease, starting with the United States. One way to characterize the burden of disease is looking at the overall number of deaths due to all causes. As part of this course, I'm hoping that you come away with a sense of what the overall numbers of deaths look like for the United States and globally in terms of the numbers of deaths each year. And this slide shows a trend line for the number of deaths in the United States from 1990, when about 2.2 million deaths occurred from all causes, to 2019, when about 3 million deaths occurred due to all causes. And so you can get a sense of the overall magnitude of these numbers in terms of the deaths that are occurring in the US each year. And you can probably guess why this trend graph ends at 2019. It's basically because the COVID-19 pandemic has really disrupted and slowed the processing of data on specific causes of death. We do have, however, good recent data on deaths that are due to all causes, so the number of deaths that are occurring, but just not great information on the causes of death in more recent years. But one way to assess the deaths resulting from the COVID-19 pandemic is to look at excess deaths due to all causes, some of which are due to COVID-19, but some of it directly, and some of them may be due to indirect causes of the pandemic as well. So this graph from the CDC shows the number of deaths occurring in the US each week due to all causes. These are the blue bars. Prior to the COVID-19 pandemic, on the left of the slide, depending on the season, the number of deaths due to all causes was between 50 and 60,000 per week, which is how we get to about 3 million per year. And using these historical trend data, it's possible to estimate the lower and upper bounds for the number of deaths that would be expected to occur each week based on historical data, and shown here by the orange lines and the red lines, respectively. You can then compare these to the number of deaths that actually occur in a given week, shown by the blue bars. And whenever the blue bar exceeds the red line, that means there are more deaths than would be expected, which we refer to as excess deaths. So looking at the graph, you can see the excess deaths, again, due to all causes, including but not limited to COVID-19. The excess deaths that occurred with each major pandemic surge in the US. Fortunately, for the last several months, on the right side of the slide, we have had the longest period since the start of the pandemic where there have been no excess deaths. This is great news, and it's largely because of the immunity that people have built over time through vaccination, through infection, or a combination of these things. This graph adds up the excess deaths and shows them by state. When you do that, you get 1.35 million excess deaths. Another way to think of that is that 10.135 million deaths occurred in the US over a roughly 3-year period, when we would have expected about 9 million or so deaths, the 3 million per year. Those 9 million deaths would have been what we expected had there been no COVID-19 or other pandemic, but we actually observed 10.135 million. And interestingly, the official death count due to COVID-19, of deaths in the US due to COVID-19, is 1.1 million. So there's a difference between the 1.35 million excess deaths and the 1.1 million deaths that are officially attributable to COVID-19. So these could be, the difference could include deaths that were not correctly classified as COVID-19, or they could include deaths that were due indirectly to the COVID-19 pandemic. For example, when people couldn't get access to health care because of surges for health conditions that they had. And they died due to those health conditions, but not directly because of COVID-19. These numbers are something that we will be processing for years to come and trying to make sense of it all. But I just wanted to give you a sense of what the latest information we have on deaths, numbers of deaths and causes of death are in the US as we moved through and continue to move through the COVID-19 pandemic. But back to the data on causes of death in the US from the Global Burden of Disease Project. Another way to characterize the burden of disease is disability-adjusted life years, or DALYs, which take into account not just the number of deaths, but also the number of years lived with disability due to a condition prior to death. So it also sort of captures information on morbidity and quality of life, as well as mortality. This is another slide from the Global Burden of Disease Project that ranks the major causes of DALYs in 1990 on the left compared to 2019 on the right. So you can get a sense of how the ranking of causes of death have changed, or causes of DALYs, I should say, have changed over time. And the color scheme has significance. So just to orient you to this, the visualization here and virtually all Global Burden of Disease Project visualizations show diseases that are non-communicable in blue, diseases that are communicable or infectious in red, and diseases that are due to external causes, such as injuries, in green. And looking at the rank here in the causes of DALYs in 1990, you can see that on the top of the list were non-communicable diseases, followed by injuries, and then infectious causes or communicable causes, which start showing up around cause number 14. And this hasn't really changed much between 1990 and 2019, but you can see that there is more movement in the ranking of other causes from one time period to the next in terms of DALYs. So, for example, substance use, largely driven by the opioid crisis, has resulted in a surge in substance use DALYs. And there's been reductions in DALYs for some areas, such as injuries, self-harm, and violence. Now looking globally, this slide shows the number of deaths and the death rate in 1990, 2013, and 2015 for the whole world. Globally, about 56 million deaths occurred worldwide and in 2015, compared with about 55 million in 2013 and about 47 million in 1990. And adjusting for age or standardizing for age, the death rate was about 850 per 100,000 in 2015, compared to about 880 per 1,000 in 2013 and almost 1,200 per 100,000 in 1990. And this slide shows the same data in graphical form, showing that the number of deaths increased from about 46.5 million globally in 1990 to about 54.7 million globally in 2016. And the death rate per 100,000 declined substantially over time. So it would seem that on the one hand, the number of deaths is going up, and on the other hand, the death rate, which takes into account the number of people in the population in each year, has been going down. So how do you interpret these two seemingly contradictory statements together? Well, one explanation is that the world's population is living longer and aging, and the population gets older and older as time goes on. And so we see more deaths as a result of having more older people. But also, when we account for age differences between the two time periods, like 1990 and 2019, you can see that the death rate goes down. So it would seem that in addition to the world population aging, there's also been some progress at preventing death and prolonging life over time, which is, of course, good news. So there's two stories here. Indeed, in terms of the population size, the world population increased dramatically between 1990 and 2020. For example, from about 5 billion to about 8 billion. So it would be expected that there would be increases in the absolute number of deaths because there's more people at risk of death around the world. And there's a substantially larger number of people living around the world as time moves on. In terms of aging, there have been major changes in the age structure of the population as well. Looking here at 3 different groups of countries: resource-rich countries on the top row, resource-limited countries excluding sub-Saharan Africa in the middle, and sub-Saharan Africa on the bottom. These are population pyramids that show the age distribution of the population in a given year for females on the left part of each graph and males on the right. And just by focusing on like the shape of these population pyramids, you can get a sense of the age structure of the population, and being, primarily sort of a chimney type form in resource rich countries where you have many people in all the different age groups, versus a largely younger population, as you see in the 1990s for resource limited countries and also for sub-Saharan Africa. So you can get a sense of how these have changed over time too. In the 23-year period between 1990 and 2013, and in all of these settings, but especially in resource-limited countries, the population has aged substantially, such that a larger share of the population is older than than was the case in the past. And this is because of improvements in life expectancy and disease prevention across the lifespan in these settings, and also improvements in disease treatment and management. People are living to older years, and that's part of the reason why the population is getting larger. And it's also part of the reason why we're seeing an increase in deaths due to non-communicable diseases, such as heart disease, stroke, and cancers, as these diseases predominantly affect older people. This slide shows the number of deaths in millions by age group for 1990 and 2013. And when you look at the number of deaths, at how the number of deaths have changed over time, the story differs depending on the age group, right? So the number of deaths declined markedly in young children, such that they are living to older ages, and the number of deaths increased rapidly in older age groups. This slide shows the global number of deaths and death rates that we looked at earlier, but breaks these numbers out by broad cause of death category. On the top row of the table, we have the number of deaths due to all causes and the age standardized or age adjusted all-cause mortality rate. The next 3 rows break this out according to deaths from communicable diseases, non-communicable diseases, and injuries. And what you can see here from 2005 to 2015, again, as we saw, there's been an increase of about 4.1% in the number of deaths, but a decrease of about 17% in the age standardized mortality rate. And calling your attention to the figures below, if you look at the same statistics by cause category, we do see substantial declines in both the number and rate of death for communicable diseases. And we're seeing an increase in the number of deaths from non-communicable diseases, but a decline in the death rate from these conditions. And for injuries, there was not much change in the number of deaths due to injuries, but there was a substantial decline in the injury death rate. So these mortality data show a fairly encouraging story in terms of death rates going down for all major categories of diseases globally. This graph shows the global number of deaths, the absolute number of deaths due to all causes by very fine age categories. And this is for 2019. And you can see within each age category, the shading represents different causes of death with a color scheme similar to what we saw before. So that you can quickly get a sense of infectious causes in red or light red, non-communicable diseases in blue or purple, and injuries in different shades of green. First of all, what jumps out is that larger number of deaths are occurring later in life. Although there is a period in life from age 0 to 4 years where there can be large numbers of deaths among very young children. And these tend to be deaths that are due to infectious causes and maternal disorders and neonatal disorders, as well as nutritional deficiencies. But as we've seen, sort of touched on, as the population ages, non-communicable diseases shown in blue tend to take over as the major causes of death globally in people ages 45 and over. Now, this graph is similar to the prior graph in structure, except now on the y-axis, instead of the numbers of deaths, we're looking at the death rate. It's the number of deaths per 100,000 population in each age group. And when we look at it this way, we see something really dramatic, which is the death rate is highest among very young children, those aged 0 to 6 days of life globally. And it drops off to be very low after about 1 year of life and stays that way for a really long time. And then beginning around age 50 or 55, we begin to see an increase in the death rate again. And the increases are pretty rapid for adults beginning at age 80 plus years. And this is yet another way to characterize the burden of disease, using it instead of the death rate this time, disability-adjusted life years, or DALYs, on the y-axis. So depending on which measure of the burden of disease you use, you get a different story. And when you look at DALYs, you begin to see that all age groups are really highly affected by different kinds of disease across the lifespan. The very young neonates, age 0 to 6 days, have the highest number of DALYs, but we now see that younger persons through childhood and adolescence are also experiencing a lot of disability-adjusted life years. We can also appreciate the different cause groups that are represented more heavily, such as injuries in younger adulthood. And some of the blue and purple shading here represents things like mental health and substance use disorders. While they don't necessarily cause a lot of deaths, they do cause a lot of disability-adjusted life years. And that's why we're seeing such a difference in the younger age groups in this measure of the burden of disease compared to ones that are primarily looking at deaths. So these graphs all highlight that there are different ways that you can think about and represent the burden of disease in populations. And you can see how thinking about DALYs due to infectious diseases, since they tend to affect younger people, contribute more to the burden of DALYs globally than they do, say, for number of deaths. And this is another visualization from the Global Burden of Disease Project using the same color scheme, plotting the number of deaths as a share of the total global deaths here. And so you can quickly get a sense, thinking about the total of the 56.5 million deaths globally in 2019, the lion's share of these global deaths are really due to non-communicable diseases in blue, followed by communicable diseases and injuries. That's using the number of deaths as the metric. The other thing that's nice about this visualization, in each smaller rectangle represents a different cause of death, and the shading of that rectangle as light or dark gives an indication of whether or not it's something that's increasing or decreasing. So the dark blue, the dark red, and the dark green colors suggest that these causes of deaths are on the rise. And so we see things here like Alzheimer's disease, diabetes, falls, and HIV were all on the rise between 1990 and 2019. And this is the same visualization, except this time we're using DALYs instead of the numbers of death as the measure of disease burden. So you can see, I'll just go back. You can see how the share of things change, right? And the number of DALYs is larger for the communicable disease category than if you would only be considering the number of deaths. And the same is true for the injury category, right? This is because these communicable diseases and injuries tend to affect younger people and they result in more disability-adjusted life years. They contribute more to the burden by this metric than they would if you were just looking at the number of deaths. As you might expect, if you look at the burden of disease according to country income group, you see a very different picture as to the major categories of causes of death. At the top here, we're looking at the number of deaths as the measure, and you can see that in high-income countries, communicable diseases represent a much lower share of the number of deaths. But on the right, in low-income countries, the majority of deaths are in the communicable disease category. Now, we've been talking a lot about causes of death and DALYs. In other words, what are people dying and suffering from? But as public health people and as students in an epidemiology course, you should also be thinking about, well, what are the real causes of death and DALYs? What are the causes that we can intervene on and use to prevent or reduce the risk of death and disability? And this graph is another visual way of looking at some of the same data we just reviewed on disability-adjusted life years, but now broken out by risk factors for the different causes of DALYs. So what are the real causes of DALYs? They're things like, things you might expect, like tobacco use or alcohol use or obesity and dietary risks. And you can look at that same data we've been looking at on the last several slides, but instead broken out by these more proximal risk factors, or I should say these more intervenable risk factors, things that we in public health are more concerned with on a day-to-day basis. So we can begin to think about which risk factors are the most important to focus on. You can see, get a quick sense of the proportion of DALYs that are driven by various risk factors in this graph. You can see dietary risks and high blood pressure and malnutrition and tobacco and air pollution making the top of the list for risk factors driving global DALYs per 100,000. So not surprisingly, these are major foci of public health activity and interventions because if we can reduce the burden of these kinds of exposures and risk factors, we can begin to reduce the global burden of disease. From a public health perspective, the best way to reduce DALYs, say due to mental illness or heart disease, is to prevent mental illness or heart disease. And in doing that, we're thinking about the risk factors we can intervene on, the ones that would have the biggest impact on the population level. And this slide also reminds us that intervening on one risk factor, say tobacco, will impact several disease outcomes and related DALYs. So this is a really useful way to visualize this information, especially for public health people who are focused on prevention. So many of the visualizations I've shown on the past several slides here are visualizations that are interactive that you can generate. And I've included a link to the Global Burden of Disease Project visualization page here. I really encourage all of you to go in and play around with these visualizations, and you can break it out. You can focus on individual countries, specific years, or drill down on different causes. And you can get to a really high level resolution on any particular topic or cause of death and disability that you might be interested in. And you can switch the metrics like we did in these last few slides, looking at the number of deaths or the number of DALYs. And I especially encourage you to check it out anytime you're embarking on a project and you want to understand the larger context of disease burden in a given part of the world or in a given country or a given time period that you're looking at. So that gives you a sense of the burden of disease and disability in the US and globally, but why is it important to understand the global burden of disease or the local burden of disease? Well, organizations that do public health need to set their priorities, and they often have limited budgets to do so and limited resources, and they have to choose well as it relates to the ways that they'll expend those limited resources and budgets. And so before we delve into public health surveillance, which is the main way that we understand the burden of disease, I wanted to briefly just touch on the mission of public health agencies like the World Health Organization, like the CDC, and like state and local health departments, because understanding these missions gives you a sense of why things like we're going to discuss in the course, like public health surveillance, are necessary. So the mission of the World Health Organization is listed here, and their goal is to build a better, healthier future for people all over the world. And they describe the ways in which they do that. Together, we strive to combat diseases, infectious diseases like influenza and HIV, and non-communicable ones like cancer and heart diseases. So they talk about some of their main priorities, the main aspects of their mission. And to do these kinds of work, it's important to understand the burden of disease around the world and in the countries where they're focusing their efforts. And moving from the global level to the country level and thinking about the mission of U.S. public health agencies by various levels, federal, state, and local, the CDC at the federal level says that their goal is around collaboration and collaborating to create the expertise, information, and tools that people need to protect and promote health. CDC also states a mission around promotion and prevention of disease, injury, and disability, and to be prepared for new health threats such as pandemics due to novel pathogens. At the state level, for example, the New York State Health Department says their mission is to protect and promote the health of New Yorkers in New York State through prevention, science, and the assurance of quality healthcare delivery. And then drilling down even further to the local level, for example, in New York City, the City Health Department's mission is stated as to protect and promote the health of New Yorkers. Each of these stated missions at the federal, state, and local level really require information so that they can accomplish their mission and evaluate their progress towards achieving that mission. They need strategic information and epidemiologic data for this. And a lot of what we'll be talking about in this course is how to go about getting some of this strategic information through public health surveillance. To achieve their goals, public health agencies need actionable data on the health of population in their jurisdiction or their purview, and they need to be able to understand the population health landscape. They need to identify and prioritize the public health agenda of programmatic activities and policies. This is needed so that they're able to understand their public health priorities for their jurisdiction and population of interest. So you can ask the question, what are the public health priorities of the world? What are they for the US? And what are they for New York State and New York City, Manhattan, and even smaller communities such as Central Harlem or Washington Heights? Each of them may have slightly different, in some cases vastly different, public health priorities. And you can begin to think about how you might go about identifying them and quantifying them. And this is where public health surveillance plays its role. On this slide, we talk about the components of the term public health surveillance and also go into the definition for public health surveillance that we'll be using during the course. Well, public health is the science and art of preventing disease, prolonging life, and promoting health through organized efforts of society. The term surveillance comes from the French for watching over. And public health surveillance is defined by the CDC as the ongoing systematic collection, analysis, and interpretation of health-related data essential to the planning, implementation, and evaluation of public health practice, closely integrated with the timely dissemination of these data to those responsible for prevention and control. We'll come back to this definition several times over the rest of the lecture and during the course. But I want to be able to be sure to distinguish here public health surveillance from epidemiology. We define epidemiology as the study of the distribution and determinants of health-related states or events in specified populations and the application of that study to control the health problems of populations. Epidemiology is really about understanding the causes of disease as well, and whether or not interventions to improve health outcomes or prevent health outcomes are effective. As you can appreciate, this is related to but different from public health surveillance. Let's further put public health surveillance into the context of the larger public health approach to disease control and prevention. Surveillance is actually the first step of the public health approach along the continuum from the health problem to the response to the health problem. Surveillance is really focused on identifying what the problem is, what the scope of the problem is, and who's affected over place and time. And then there are subsequent steps of the public health approach that surveillance can inform that really may fall in the realm more of epidemiology or assessing the effectiveness of interventions. For risk factor identification, we're focused on what the potential causes of the problem are. This is not necessarily a focus of surveillance, which is really aiming to identify what is the problem. While public health surveillance may provide some insights about the causes of a health problem, often more rigorous epidemiologic studies are needed to identify the true causes. Once causes are identified, another step in the public health approach is developing interventions and identifying those interventions that work to prevent or reduce the burden of a health problem. Ultimately, once you identify those interventions that work, how do you implement it? How do you scale it and get it to the larger populations that may need it or benefit from it? Finally, I would argue that there's a feedback loop here. Once you begin to implement interventions at scale, surveillance then has a role to answer questions like, well, does the intervention implementation that's going on at scale, aiming to address a particular health problem in a population, does it actually have an impact? Is that impact something we can detect in the surveillance data such that we can see an impact on prevention and or the reduced burden of disease? So there's an important feedback loop that you can envision here, which represents the role of surveillance in assessing the impact of programmatic public health interventions or policy implementations. at scale. And we'll talk about examples of this later on in the course. Also, to further help contextualize public health surveillance a little bit before we dig deeper, some of the purposes of public health surveillance include the need to assess public health status, the need to define public health priorities. What, for example, are the leading causes of death? What are the leading causes of preventable death? And what are the leading causes of DALYs? And as I alluded to earlier, surveillance can really be useful for evaluating programs that are aiming to improve the health status of populations. And finally, surveillance can also be used to stimulate research that gets further at causes and potential interventions that may be helpful to public health. So that wraps it up for this section, and there'll be more lectures for session 1 of the course that you'll find on the Blackboard site.